of, alluded to this, but I'm gonna flip us a little bit, right? We're talking about upper tract disease and recurrence rates, and one of the most common places that you would worry about a recurrence after doing these ablations would be the bladder. So tell me how people think about the future bladder when they're doing any sort of ablation of the upper urinary tract or doing a surgery on the upper tract, such as a nephroureterectomy.
Yeah, so I guess I could start with the nephroureterectomy. So in my practice, I routinely use intraoperative gemcitabine. I actually put the gemcitabine at the start of the case, and then as we get closer down to the bladder cup, drain the bladder, do just a very gentle CBI, rinse it out, and then do the cup at that point to kind of protect the bladder.
I'm going to predict that it's going to become standard of care to give gemcitabine at the time of ureteroscopy, because I think that there's not a lot of data now, but I think there's going to be data, and there's some data, and I think that, and I personally actually I have not started doing it. I know colleagues that have, but I think I'm going to, and I think it's going to be an important part of what we do. We do it at the time of TURBT. We're causing cells to disperse at the time of ureteroscopy, and probably we should start doing that again. No data yet, but I think that will come. I agree. In terms of at the time of nephroureterectomy, I do gemcitabine also. And then what do you do if you have bladder tumor at the same time as your upper tract tumor? Perfect time to treat both, right? So you treat both. But the one thing that it's very easy to think, oh, I'm going to get a twofer with this Jelmyto. I'm going to be able to treat the kidney and then treat the bladder. It doesn't really work for the bladder because it's too dilute as it comes down and diffuses over 4 to 6 hours. So you have to treat the bladder separately.
Sure.
So as my standard practice, whenever I take a patient for ureteroscopy for upper tract tumor, I always give gemcitabine in the bladder with or without bladder tumor. The way I explain it to the patient is, there's a rot-down effect, right? Things fall to gravity. And if there's any circulating cancer cell in the bladder, the idea is that it will prevent, and it's been shown to prevent recurrence in the bladder literature very decisively. And then at the time of nephroureterectomy, I take the bladder cuff. So it depends. I actually, just as a standard practice, I always perform cystoscopy before I do the nephroureterectomy. That's pretty easy to do to make sure that there is no bladder tumor. If there's bladder tumor, I'll take care of that right there and then before I open the bladder cuff because I don't like surprises. And then once I, do the bladder cuff, I put patient back in supine position, and I put gemcitabine in their bladder for an hour, and that's 2 grams of gemcitabine in 100 ml of normal saline.
So I'm curious, you do a full cystoscopy and lithotomy before at the same setting as your nephroureterectomy?
Yep.
And then reposition them?
No, so before I always put a catheter in before a nephroureterectomy.
Yeah.
So before I put the catheter in, I would do the flexible cystoscopy.
Yeah.
So for men, they just supine, and women I'll do front-like position, make sure that there is no tumor in the bladder.
But if you see something, you then do a TURBT.
If I see something, then I'll do TURBT at the same time to just get rid of it. And if I do a TURBT, I put chemotherapy in at the end of TURBT. But if I don't see anything, then I'll do the bladder cuff, and then at the end of the case, I put gemcitabine in the bladder.
So you do it after doing your bladder cuff and close the bladder. That's when you put the gemcitabine.
That's correct.
Interesting.
If there's no tumor in the bladder, because the idea is prevention.
Right.
Interesting.
Yeah, I placed the gemcitabine at the start of the case. So I put in the 2 grams of gemcitabine, and once the catheter is placed, and then once I divide the hilum and clip the ureter, then we drain the gemcitabine and then start some continuous bladder irrigation, let it wash. So.
The only, my only rationale is that patients are typically in a more lateral position with the ipsilateral side, the side with the cancer up. So, the idea is you continuously drain the urine and getting any fluid away from that side. So my only concern about doing that during the case is that the area that I want to be in contact with the chemotherapy are not in contact. It's just a hypothetical scenario, but I probably obsessed too much over this.
That's what we do as surgeons, right?